Hello, 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 hello. Sound test one, two. Hello, hello, hello. Check one, two.
हाँ जी, आपकी आ रही है, आपकी आ रही है और प्रेजेंटेशन भी नजर आ रही है। थैंक यू।
जी अस्सलाम वालेकुम।
अस्सलाम वालेकुम। हाँ जी, ये आपकी आवाज भी आ रही है और प्रेजेंटेशन वगैरह नजर आ रही है इसमें। ठीक है, तो आपकी जो स्क्रीन है
डिस्प्ले
ना,
भी
तो
आ गया
आप
आपके
इसमें।
पास।
जी जी, एग्जैक्टली।
ठीक हो
बिल्कुल।
गया था।
कैमरा 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 है आपका ऑन? मेरा ख्याल है नहीं है।
कैमरा फिलहाल
कैमरा।
बंद है।
ठीक है।
हाँ ठीक है, वो भी वो हो जाता है।
बहुत शुक्रिया, बहुत शुक्रिया।
हाँ
थैंक यू सो मच।
डिस्प्ले आ
हाँ
गया
जी,
आपका।
बिल्कुल सही है। थैंक यू सो मच।
वेलकम जी, वेलकम मैडम।
formally start the workshop lectures and courses. First of all, I will request Dr. Ghulam Nasiruddin to please come on the stage and recite few verses of Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إنا أعطيناك الكوثر فصل لربك وانحر إن شانئك هو الأبتر صدق الله العظيم.
Jazakallah. Now I will request Professor Fozia Sajjad to please come on the dais and have a welcome note to everyone.
Assalamu alaikum. On behalf of Department of Neurosurgery, General Jinnah Hospital, Lahore, I welcome you all. I am very grateful to all the distinguished guests, the participants, and dear colleagues who spare their time for this activity, for this endovascular workshop. I'm really grateful to Dr. Akil, who is really, Pakistan has always proud on son of his soil, who got expertise in abroad and who never hesitate to share their skill and knowledge with their countrymate. Welcome you, sir. I am grateful to Saima. She is really a warrior, a fighter. She is the person who is behind this workshop. Without her hard work, it was not possible to arrange this workshop here in Jinnah Hospital, Lahore. Thank you, Saima, for your great contribution. I am really grateful to my teachers, Professor Dr. Abdul Hamid and Professor Dr. Akmal and Sundas, who really came here and help us in managing this event so that we can share our experience. As we discussed earlier in the morning, the vascular neurosurgery really is primitive in Pakistan. And we need, although here people are doing vascular clipping, that is not a difficult task for a neurosurgeon, but we want expertise in the ECIC bypass, the bypass surgeries in the brain, as well as the better stenting in endovascular embolization and the coiling and all these expertise. As this is the need of the hour, it's necessary to choose the best approach, the best, safest approach for the patient to save the life as well as to treat the lesion. I am grateful to all of you. Thank you so much. And over a next few hours, inshallah, we will got knowledge about the recent advances in the vascular neurosurgery as well as endovascular embolization, and later the how we will proceed in the excision of avium in spine. At the same time, I am also grateful to Mr. Kaleem, who has traveled from Combined Military Hospital with all his gadgets for providing us the facility of intraoperative neuromonitoring. He will join us in Operation Theatre. Thank you very much. And again, I welcome you all. Thank you so much.
Thank you so much, Professor Fozia Sajjad. As a few of our participants who really registered themselves to listen to your lecture, sir. So for ICP monitoring, brain microdialysis, and all other gadgets of neuromonitoring, including brain oxygen and cerebral temperature monitoring. So we are treating the head injury patients with all the advanced gadgets which any advanced country can have. Along with that, he again established a closed intensive care for neurosurgery. So we have a 16-bedded intensive care under this one roof, and that intensive care has 8 beds of ICU and 8 high dependency units. That is also equipped with all the monitoring gadgets and all the gadgets needed in an ICU. Why we called it a closed neuro ICU system? Professor Naveed was under the impression that in ICU, when we have any patient choking with any mucus plug in his tracheostomy tube or the tube, we call the pulmonologist to come over and do the bronchoscopy and all that. But he bought a bronchoscope here. He trained all the residents to become used to the bronchoscope, so that we can do that immediately, because in Pakistan it's very dangerous to call on a pulmonologist at mid of night when a patient is choking. You cannot wait. So he was under the impression that neurosurgical ICU must be headed by the neurosurgeon and must be done. All the work must be done by the neurosurgical team, and that's what we are doing. Professor Fozia, and after that, Professor Manzoor came here, and he did a commendable job in his 1.5 year era. He taught all the residents the basic neurosurgery, the spine, and after him, Professor Fozia Sajjad came here. She's also student of Professor Naveed Ashraf. So she was also fond of the vascular neurosurgery, and that's why we are having this workshop. So it's around 1 year that she's here. And in the last 1 year, we started the vascular neurosurgery again. So now where we are standing, we have a complete unit of vascular neurosurgery. We have a good operation suite. We have 16-bedded neurocritical care unit and a team. Finally, I will like to introduce you to the neurosurgical team. Professor Fozia Sajjad, she's professor and head of the neurosurgery department. Dr. Nabil Chaudhry, he's sitting on the right side. He is the associate professor of neurosurgery. Dr. Usman Ahmed sitting on the second row. He's assistant professor, and I am Dr. Kashif Sultan. I'm also assistant professor of neurosurgery. So this team has 1 professor, 1 associate, and 2 assistant professors, and 1 senior registrar, Dr. Ghulam Nasiruddin. He is in the team of the vascular neurosurgery of this department because he's fond of your work, sir. So this was a very brief introduction. This was a very brief introduction of this department. So I'm thankful to you that you listened to it and participants could reach. So now, with your kind permission, madam, let's start with the lecture of Dr. Akil. Sir, I invite you to please come over and start your lecture. Thank you.
Assalamu alaikum and good morning. Thank you very much for the kind introduction. Let me just begin by saying I'm honored and I'm humbled to be here, essentially basking in the historical glory of this department, mashallah. And I think forgive me for my bias because I'm from Karachi. But I've come to Lahore after about 20 some years. The last time I was here when I was in second year of medical school, and I had some friends from Lahore that had invited us over at that time. But I will say that during my time here in Karachi and in Lahore thus far, about 24 hours now, I've been very impressed, alhamdulillah, with the enthusiasm that I've seen regarding vascular neurosurgery. Vascular is near and dear to my heart, and I'll tell you why. is because when I started training in the US in Detroit, my biggest mentor was Dr. Ghaus Malik, as we were talking about. And Ghaus Malik is a legendary name in vascular neurosurgery. So I trained under his wings. But when I graduated after my training, I had no endovascular experience because our residency program was not very robust in training neurosurgeons at that time. I went into private practice for a few years. And at that time, I realized that if I'm not trained in, at least in the West, if you're not trained in endovascular neurosurgery, you might as well give up vascular neurosurgery practice altogether, because the way the patient referral system works and the way you're able to capture patients and treat them, you have to be able to provide a comprehensive cerebrovascular care. And so it was very hard for me. I had a, alhamdulillah, established practice. And I left that practice to go back into fellowship, and then did my endovascular fellowship. And then, alhamdulillah, at Emory University, I did my fellowship and I stayed on as faculty there. So that's what I am right now. But beyond that, I think, to your point, I think of all the people, I stand on the shoulder of giants, people who trained me, Ghaus Malik, Athar Inam, and the rest of the people in Detroit and in the US and in Pakistan. I think no matter where we go, where we end up, I think we always have to reflect, look back, and make sure that we have gratitude for our teachers, for our professors. And although this is my first time meeting Professor Akmal and Professor Abdul Hamid, but I can already sense that I'm their student, because they have already trained people. And I'm sure through some connection, I have learned from people who you have trained. So I'm very grateful for that. Moreover, I'm very grateful to Dr. Fawzia Sajjad, because she has opened her institution, opened her heart to host this workshop. And obviously, Dr. Saima, who has been with me since the last year, and we have been trying to put things together, alhamdulillah. I don't know if this is truly an endovascular workshop, because yesterday we had a very busy day. Dr. Usman and Dr. Nasir we were together yesterday at the Farooq Hospital, and we did some cases from morning till night. So I'm sorry if I yawned during the talk, because we had a long day yesterday. But today, what I'm trying to do is, and this is my bias, so forgive me for that, but being a neurosurgeon, I fully believe, and please disagree with me, I think neurosurgeons should be the one who should take charge of vascular problems in the brain and spine. And now, whether it be aneurysms or stroke or AVMs, I think we are in the perfect position to deal with these pathologies like no other specialty can. Now, I'm sure you're aware, we have neurology and radiology who are in this space, which is great, because some of my professors who trained me, especially endovascular, were neurologists and radiologists. But at the end of the day, I still think that as a neurosurgeon, we are able to look at both sides of the coin and then decide what's best for the patient. So I'll show some, I'll try to keep my talk entertaining, and I can take questions, and we can have comments, and Professor Saab, please feel free to slap me on the wrist if you feel I'm saying something which might not be perfectly true. But I think this is a great opportunity for me to learn from you, and for you to share your experiences, so because I know things are done differently in different parts of the world. I mean, when we were in Islamabad last year for the MENA Sino conference, I realized that the way I do things in the US is completely different from what they do in Thailand, from what they do in Singapore, from what they do in Philippines. And so, and then since I've been here, I'll be honest, some of the endovascular tricks that I've done in the cases, because of limited availability of tools and whatnot, I was amazed by how you have to sometimes innovate on the go, because you might not have all the catheters at your disposal. So yeah. So with that, we'll just sorry. Let me just fire this up. All right. How much, Dr. Fawzia, how much time do I have? No, I'm sure other people have. Okay, we'll try to keep it brief so we can have time for questions and comments. So this is Grady Hospital. This is part of the Emory University teaching level 1 trauma center. This is where I work. Great hospital. It's a 1,000-bed facility. It's one of the largest and the busiest trauma centers in the US. So just because I'm guessing, so is everybody a neurosurgeon here or related to neurosurgery somehow, or do we have other specialties as well?
One radiologist.
जी, वो आधी neurosurgeon तो हो गई है वो भी, जी हाँ. But okay. All right. So and I'm guessing there are all levels from starting from residents to professors, right? So we're going to start a little basic. So forgive me, this is boring for you, but not too basic, but just all right. So what's cerebrovascular surgery? So traditional method of treating neurovascular disorders of the brain spine, and that includes clipping, AVM resections, and then obviously Dr. Fauzi was talking about cerebrovascularization of bypass, and that's near and dear to my heart, and I'll tell you why in a little bit. Bailout or last options. So when sometimes endovascular gets stuck, it's cerebrovascular to the rescue, and then vice versa. And then carotid artery disease. Unfortunately, we have sort of, at least I don't know about Pakistan, but in the US predominantly, we have given up endarterectomies to vascular surgery. Alhamdulillah, when I started practice, I tried to reclaim that, and now I'm doing more endarterectomies in my hospital than the vascular surgeons, because I feel we have the knowledge of the end organ, and so there's no reason for the vascular surgeons to be doing this, because if they send an emboli into the brain, then they call us, and then that becomes our problem. So if you cannot take care of the end organ, like if they get a hyperperfusion hemorrhage, something like that, they can't do anything. I think it is the whole and sole responsibility of the neurosurgeon to take care of this disease surgically or via stenting, so that if something happens distally, we should be the one to own this problem, and not, you don't have too many cooks in the kitchen. But that's, again, my opinions are biased, and I understand that. Endovascularly, people typically think it's a minimally invasive way of treating neurovascular disorders. I like to think it's a less invasive way. Just because you don't see a big incision doesn't mean it doesn't have inherent risks, right? So, sure, we put catheters and all that stuff, but we can cause damage. We can rupture arteries, we can rupture aneurysms, we can occlude vessels that, we can send glue into places that it shouldn't go. So just because if it's done through a small nick in the wrist or the groin, doesn't mean it's not dangerous. People have this, it becomes almost an advertising gimmick, about, people talk about minimally invasive spine surgery. I think, like, for minimally invasive spine surgery, I still call it like less invasive but more destructive, because you go in there, you don't see what you're doing sometimes, and people are trying to put in endoscopes and whatnot, which is great. But I think at the end of the day, we have to understand the work that's been done. It's still, still patient at risk, and there's neurovascular structures that are still at risk. So yeah, so by no means should anybody think, at least in this room, hopefully after this talk, that endovascular neurosurgery is just, oh yeah, it's very easy and it's less invasive and it's super safe and nothing bad can happen. No, a lot of bad things can happen in endovascular surgery as well, which we'll look about. But that predominantly talks about, we care about aneurysm treatments like coiling, stent or balloon assisted. Fluid diversion has been around for like about 20 some years, and the technology keeps getting better. Tumor AVM, AV fistula embolization that we did yesterday, for instance. We can help other specialties like ENT when they have to do a carotid sacrifice for let's say a glomus tumor. So we can do a balloon test occlusion for them to see what the cross-filling looks like if they have to sacrifice the artery. We can do a WADA test for neurologists when they have to test speech and memory testing, and for epilepsy patients when the epilepsy surgeons want to do temporal lobe resections. And then again, carotid artery stenting, because obviously that's a very it's a wonderful technology, less invasive, faster recovery. And then eventually, more recently now, we have middle meningeal artery embolization being done for chronic subdural hematomas, and intraarterial chemotherapy, for instance. We do it routinely for children with I'm going to stop here. Do you know which tumor do we do intraarterial chemotherapy for routinely, or that's approved? Retinoblastoma, exactly. So we do retinoblastoma treatments. So, traditionally there has been this war that has been going on between endovascular and open vascular, but it shouldn't be like this. I think over time we have become accustomed to the fact that they need to work in a complementary fashion. But then I'll probably go a step further, where I think the new generation of cerebrovascular surgeons need to be this warrior, where you have to have both tools in your hand, right? You cannot just do one without the other. So, back in the days, we'd be like, okay, well, I'm a neurosurgeon, so I'll stay in the operating room, and you're an interventional radiologist or neurologist, and you should stay in the angio suite. I think that boundaries are slowly fading away, and I think that two specialties are significantly merging now. And if as neurosurgeons, I think if we don't take charge of this situation, same thing will happen to us. What happened to the cardiothoracic surgeons, where cardiologists just basically pushed them to the side and relegated them to 10% of the pathologies, and they sort of took over the specialty, right? Because the way I can tell you this is the way endovascular is now developing at a rapid pace, and the newer technology comes out every year or two. I would not be surprised in 20 years we would do half, maybe a third of open vascular cases that we're doing right now. So we just have to stay ahead of the curve. So I don't call it a cerebrovascular or endovascular neurosurgery. I call it neurovascular surgery because I think that's the right term to use. So if you have patients who have aneurysms, you should be able to offer them all these treatment options, right? If you have a patient with AVMs, you should be able to offer them embolization, resection, or if they need radiosurgery. Same goes for AV fistula. So if, you should be able to offer them all these treatment options. And if somebody comes with a stroke, either chronic or acute, you should be able to offer them stenting and arterectomy. TCAR is this new thing that's being done now. And mechanical thrombectomy. That's the burden of disease is humongous, especially in our part of the world. And the benefit of thrombectomy, if you think about this, the only other thing that has proven as much treatment efficacy as mechanical thrombectomy is antibiotics and sepsis. So nobody in our medical community will say, oh, role of antibiotics is controversial in sepsis. It's not, right? So same thing, role of mechanical thrombectomy is so well established that the number needed to treat is like 3 or 4, right? Number needed to treat for endarterectomy is like, for even symptomatic patients, is almost 15. Number needed to treat for PCIs is, I think, 8 or 9. So number needed to treat for thrombectomy is like 3 or 4. So you do 2 or 3 or 4 thrombectomies, you essentially are saving one life. So it's the impact is massive, right? I've had patients who come with an M1, like, for instance, I don't remember the last time I did a decompressive hemicraniectomy for a MCA infarction, because by the time the patient comes to us, we just go in and we open the vessel up, and you reverse all these ischemic changes, and patients don't need to undergo decompressive hemicrania, and most of them will get better and will go back to their routine lifestyle. So the recovery is massive. So everybody knows about aneurysms and subarachnoid hemorrhage, so we don't want to go too deep into that. Unfortunately, the trials we keep referring to are back from 80s and 90s, maybe even before at least I was born. And so we talk about these ischua and how that tells you that the chances of rupture of the ischua of aneurysms in the anterior circulation, which are less than 7 millimeters, don't rupture. It's 0%, but we all know that's not true. Obviously, previous subarachnoid hemorrhage puts you at a higher risk. But anyways, more recently, I don't know about you all, but in our clinic, we typically use these scores, the phases scores, and on the next slide, there's a UI-ATS score. We use these scores to really, because we see a lot of incidental aneurysms there. I know that's not the case here, but so if somebody comes with an incidental aneurysm, we need to have a more objective way of determining if we need to offer them treatment. If they're ruptured, then there's no question you have to treat them. But if they're not ruptured, then it's just not the size. Most people just go by the size, but you have to look at their family history. You have to look at their smoking status, and all these things, the features that you're seeing here on the screen, and then come up with a score. And then because you have to publish this, because if something goes wrong, it's a litigious society, so they can come back and sue us and say, hey, why did you treat this 2 or 3 millimeter ACOM aneurysm that didn't need to be treated? Everybody knows imaging modalities for aneurysms, MRA. We almost never use that unless we're screening somebody or following up after treatment. But CTA obviously is more common. And then at the end of the day, it's the digital subtraction angiogram. And I was just at a course at Akhan, and I kept telling people that you need to know how to A, do the DSA, and then B, how to interpret it, because this is the only dynamic study that we have. And so unless you are really familiar with interpreting and looking at the angiograms, you really should not do cerebrovascular surgery, because the vascular surgery is all about blood flow and its dynamics and early arterial thinning and so on and so forth. And so we spend a lot of time at that course going over the angiogram and its dynamics and so on and so forth. The other benefit of that is you can do 3D imaging now, like in our case yesterday with a kid with the ACOM. You can really look at the neck and with different different machines will give us different ideations of what aneurysms can look like, and you can do different measurements because that is necessary, because we have so many different devices nowadays that we can use to treat these aneurysms. So the goal of aneurysm treatment is to prevent rehemorrhage, but the ideal treatment needs to be safe, effective, and durable, most importantly, right? So if somebody, if it has a wide neck aneurysm and you don't have a stand and coiling is going to be difficult, then just clip it, right? Simple as that. But if somebody is old or has a fusiform aneurysm, and or a blistered aneurysm, let's say, clipping is going to be dangerous because the vessel will fall apart or will get compromised, then endovascular is the way to go, right? And so for each patient, this needs to be a very tailored plan. It's not one size fits all, right? So so at the end of the day, what do we have? So let's talk about that. What do we have in our toolbox? So from a surgical standpoint, we typically have like basically two things, right? We have the aneurysm clips, and then if you're comfortable, you can do high or low flow bypasses to trap aneurysms. Again, this is not very common. I think since endovascular has come along, these cases have come very far few in between. I probably do maybe one, maybe two bypasses a year for aneurysms. I do more for moya disease, for cerebral revascularization. But yeah, I mean, thanks to, like, for instance, something like this aneurysm that you see in the picture on M1, if we have to treat this nowadays, you can just put a floor diverter through it, and the vessel will remodel around the floor diverter. The lenticular striates will stay open, and then that'll take me 45 minutes to do that case, instead of doing this high flow bypass will take maybe 8, 9, 10 hours, because you have to harvest the radial artery and expose the neck and so on and so forth. So they're not small, they're morbid procedures, and then obviously you have to clamp the MCA, and there's ischemia time and so on and so forth. Obviously, in endovascular, we have simple coiling. This is a stent assisted coiling, balloon assisted coiling, as we were talking about, and then now more recently we have these intrasaccular devices, even for wide neck aneurysms. This is a device called Webb, woven endobridge, that you can just put in the aneurysm. If you size it properly, it hugs the wall of the aneurysm and stays there. Deploying this takes 5, 10, 15 minutes. So you can basically treat a basilar tip aneurysm in 20 minutes, even long before the craniotomy is done, let's say if you were planning a clipping, right? And obviously flow diversion, I'm sure everybody knows about that. We have pipeline and surpass are the two big devices that everybody uses. This is a sort of a neck bridging device, but it's a wide stent sort of a thing, but we don't use that anymore. This is a Medina coil. I've never used it, but now we're trying this device called Contour. It's called a neck bridging device. So instead of filling the aneurysm, you just basically deploy this device at the neck of the aneurysm, and that will help to secure the aneurysm. I haven't done that. There are like 3 centers in the US right now that are just trialing it because FDA is always really late in these things. So surgical clipping has been around for 80 plus years, and there's a long history of clipping, and we have good track record of that, right? So however, it requires craniotomy, it requires manipulating the brain, but once the clip is applied, the aneurysm is done, right? So if you don't have a residual or a dog ear, the aneurysm is considered cured, and you don't need to keep following those patients up. But obviously that's not the case with endovascular, as we'll see. So this is a simple, some simple videos. This is a ACOM aneurysm that's being approached from the left side. You have a temporary clip on the A1. Obviously, I teach my residents that they have to make sure that they see the A1s on both sides. They can find the A2s on both sides. That's the contralateral A1 right there. Is everybody able to see the videos clearly? Yeah, do we need to turn the lights down a little more? Okay. And then obviously, once the aneurysm is nicely laid out, then clipping it is easy. And once you clip it, the problem is solved. So we don't really have to bring this patient back for any additional treatments or follow-ups and so on and so forth. Some treatments obviously could be a little bit more complex. So this is I don't want to belabor this, but this is a sort of a more complex multilobulated MCA aneurysm that we did recently. And I like for my residents and my fellows to really expose the whole anatomy so that they can understand what's what, because sometimes you will have an MCA trifurcation, or you can have multiple branches coming off the ACOM. There could be 3 A2s, like an accessory A2. And so you want to be able to make sure that you see everything before you put your clips on the aneurysm, because once the clip is on, and if you have grabbed another vessel, that vessel will go away, and the patient will get a stroke, right? So So here you can see where that's a big MC aneurysm that's on right about there. But we're trapping the aneurysm by putting clips on M1 and M2. That's another M2 right here that's coming out the base of the aneurysm. This is one of those aneurysms that we couldn't do a flow diverter or coiling off. So obviously it's a large aneurysm, so we decided to deflate it. Right, so you can put a needle in there, deflate this aneurysm, right? You can see that right there. And then once that happens, then you can negotiate your clips to clip it effectively. And then we also do intraoperative angiogram, at least in my shop, because that will tell me we can do ICG, but ICG will show you what you can see in the field. It will not show you what's hidden behind it. But with the intraoperative angiogram, you can really see what you did in the angio suite. And after clipping what you're seeing, if you're missing a branch, you will pick that up on the angiogram, and then you can go back in and fix your clips. Posterior circulation aneurysms, most people have now shy away from clipping these aneurysms. This is one such aneurysm that's a SCA aneurysm that doesn't really have good endovascular options. You can try to put a stent going into the SCA, but that is a lot of maneuvering. The aneurysm is at the shoulder of the SCA, and it will take a lot of acrobats, let's say, to get that stent in. And so, just because if you're well trained in clipping aneurysms, then posterior circulation aneurysms should not be dramatically different than technically anterior circulation aneurysms. Obviously, it's more dreaded now because of our training restrictions, because we don't just do them that often. But for this case, for instance, we did a subtemporal approach. And once you put the lumbar drain in, you relax CSF, and you take your time, these aneurysms will become very apparent right there. And so you have the basilar in the background, you have the SCA, the superior cerebral artery aneurysm is sitting right there, and you can just put your clip on and fix it once and for all. And I think that's less risk rather than trying to put your catheters in like what we did yesterday and trying to flip the catheters and do all those things, because that can easily rupture the aneurysm, and so you don't want to do that. All right, so moving on to endovascular, obviously it's a shorter and simpler procedure. Sometimes it can take forever. They're less invasive and the shorter recovery. However, obviously the coils can get compacted, the aneurysms can easily recur. They require angiographic follow-up, and overall cumulative experience compared to microsurgery is less. These are what we talked about. However, over the last 20 years, we've gone from being a typewriter to being this first generation Apple computer to Mac, right? So it all started with these GDC coils back in the 80s, and we went up to stents and flow diverters, and now we have these web devices. So progression has come at a rapid and almost a neck-breaking pace. This is just a simple and I just want to spend a little bit of time on this because most of us here in this room do not do endovascular. Coiling might seem pretty simple and straightforward, but as we learned yesterday, there's a lot of mechanics, because when you put the coil in, there's a lot of vectors at work, and the catheters can go back and forth, get kicked out of the aneurysm. Just getting the catheter into the aneurysm is obviously hard, but once you get it there, and obviously we can talk about this later if somebody is more interested, you try to deploy these coils as much as possible so that the blood flow can be interrupted. There's balloon assisted coiling that helps. There's something called stent assisted coiling. We have multiple companies now that make these stents, and I just recently actually did a case back in Karachi where we had a patient with a pretty large ICA terminus aneurysm with a wide neck, and this case is also a little bit more tricky because you have to negotiate two catheters, and it's, obviously these animations make it look very easy. But you can move one catheter that will pull the other catheter out, and obviously you're working in a limited space. The vessel diameter is 3-4 millimeters, not more than that, obviously, right? So any movement or any maneuvers you make has downstream consequences. So this is one way to do it. You deploy the stent, and then the stent will form a scaffold across the neck of the aneurysm, and then you can put coils behind it, right? And so that takes care of it. And then you have to put the patients on dual antiplatelet treatments and so on and so forth. So that's an example of that. So the concept of flow diversion, everybody's familiar with flow diversion, I'm guessing, yeah? Yes?